Hi, Dr. Charles Soparkar. I'm here today to talk to you about blepharospasm and dry eye and how dry eye impacts blepharospasm. And let's talk about understanding dry eye and the tear film and how that impacts blepharospasm. And let's talk specifically about tear film lipid biochemistry, surface tension properties of tear film, cytokine modulation, inter- and intracellular signal transduction, immunomodulation and cytochemistry, and cell surface markers, the important things in the tear film. Well, on second thought, let's not. That's all very complicated and it's very real and important, but you won't understand it, and I don't understand it. And if we really want to take something away from this, we want to keep this simple. And simplicity, of course, is beautiful, so let's keep this simple so we can understand what we're talking about. And I also want to say that as physicians, we make assessments, but much of our treatment decisions are based upon what you tell us. And we depend on you to tell us all the important information. No physician can possibly give your problem as much thought or attention as you can. If you understand your disease, you understand your treatment, you can affect a positive change in your life. And I think the more you understand your problem, the more likely that is to happen. So let's talk about this tear film and dry eye problem in two parts. The first part will be to understand what dry eye is, and the second is to understand what we can do about it today and what's likely to happen about treating dry eye in the future. So understanding dry eye and how it impacts patients with blepharospasm. There are different kinds of blepharospasm, and let me just run over this quickly and say that we're all familiar with the primary forms of blepharospasm. The spastic, where the muscles are contracting and you can't open your eyes. The apraxic, where your eyes just seem to close and no matter how you try to open them, you can't. And the combined, both the spastic and the apraxic, and most patients have some of both of those issues. That's primary benign essential blepharospasm. Secondary blepharospasms are what we will focus on today in just a few moments. There are, of course, complex secondary blepharospasms, which are related to systemic diseases, and habitual blepharospasm, and these are typically what we see in children who, by habit, frequently blink. But let's talk about the secondary blepharospasms. If we have eyes, a pair of eyes, and we take a sharp instrument and we poke them in the eyes will blink. And that's true of any irritant. Any irritant that you place on the eyes will cause the eyes to blink. And that might be pollens, it might be allergens, other allergens than pollens, smoke, other pollutants in the environment, toxins, and the most common toxins that we present to the eyes are those we find as preservatives and teardrops that we put in the eyes. Bright glare, eyelashes that are turning in and rubbing on the eye will cause you to blink frequently. Wrong spectacle correction. If you have the wrong glasses, you might frequently blink. Stress will certainly cause frequent blinking. And dry eye. Dry eye is a very common problem. Up to 30% of the population has a dry eye problem. And over 30% of all medications that we take increase dry eye symptoms, sometimes with great frequency, and perhaps the worst of these are the antihistamines that we frequently take, especially in the Houston area where people have so many allergies. And perhaps as many as half of all patients with blepharospasm have dry eye. So it's a significant problem causing secondary blepharospasm. What is dry eye? Well, we don't really mean dry eye. What we mean is an eye irritation that results from a tear film problem. And perhaps we're better to call this dysfunctional tear film syndrome. However, that's a mouthful, so we'll stick with dry eye. To conceptualize the problem, here's a bucket, and here's a ball that we toss into the bucket. The bucket represents the eyelids, and the eyeball is represented by the ball. Now, we make tears all the time. We have to in order to keep the eye lubricated. If we don't, the eye will dry out, and that's not only very painful, but it's very dangerous for the eye. So we make tears, and that keeps the eye nicely lubricated. But we have to have a tear outflow system, otherwise the tears that we produce constantly will overflow and pour down the face. And this is the homeostatic situation that we like, where tear production and tear outflow equal one another and keep the eye well lubricated. And this is a model of what we see in real life. Here's a picture of an eye and a nose. The nose is down toward the left side of your screen, and the eye is over on the right. And up in the top right corner is something called the lacrimal gland. And this is one of the things that makes one of the components of the tear film. And here we see it making the tears, which then drain down the nose into the back of the nose and the back of the throat. And that's why when you cry, your nose runs, because this is the normal egress of tears from the eye. So here's our model. And if we have too little production or too rapid outflow from the system, you'll have a dry eye. Sometimes we treat dry eye with punctal plugs. We clog up the tear drain, and this keeps more fluid on the eye. This is not always a good thing, because the tears may become toxic, and you can have a toxic tear syndrome or toxic tears causing a dry eye problem, and we'll talk more about that later. So I told you that this is the desirable system where we have tear production equaling tear outflow. If you have a low tear production, you might clog up the tear drain, but you can still get a dry eye because the rate of evaporation then is greater than the rate of tear production. So even with low tear production, you can get a dry eye even with a punctal plug. You can also have too much outflow, so the rate of outflow is greater than the rate of influx of tears, and of course that will give you a dry eye problem as well. So too little production or too rapid outflow gives you a dry eye. Now, the system is a little bit more complicated than that. It turns out that we actually have a multitude of different glands that make tears, and they make different components of the tears. And there's one big gland called the lacrimal gland that I showed you before. And this big gland is used mostly for reflex tearing. And what that means is that when the eye is irritated, this big gland turns on and produces a tremendous amount of water component to the tear film. So when you have a dry eye situation, you may have a compensatory overproduction of this water component to the tear film. And that's why some people who have a dry eye will have a tearing eye. Their eye is really dry, they go out in the breeze, and all of a sudden their eye starts watering. What's interesting to me is that many patients with blepharospasm don't seem to have this compensatory mechanism. So many patients with blepharospasm, although they have a dry eye problem, don't actually have a reflex tearing excess. Now let me give you an idea of the tear film in more microscopic detail. Here's the eye surface. Here's the outside world that's causing irritants to the eye. And there is a protective barrier between the outside world and the eye surface as the water layer of the tear film. It's the powerhouse of the tear film, filled with all kinds of goodies, proteins, nutrients, healing elements, bacterial protectants, etc. Most of the good things that we need in our tear film to protect our eye from the outside environment. This tear film, the water layer, is attached to the eye surface by the mucin layer. And this permits an even flow of the tears over the eye, and different glands make the mucin from those that make the water layer. On top of this whole tear film is the barrier layer, or the lipid layer, the oil component. And this prevents tear evaporation or particle penetration into the tear film. It also provides a good optical surface. What does that mean? If I go underwater and I open my eye underwater, I can't see anything. Unless I put a mask on, and now I can see under the water. The lipid layer is like that mask that allows us to see in air. And without that lipid layer, we can't see properly. We can't see through the water layer. So we need that for a good optical surface. And it's a highly regulated layer. A lot of different components go into regulating the lipid layer. There are nerve signals and hormonal signals and blood vessel factors that influence the lipid layer. So here's another picture of the same thing. Here's the eye surface, the mucin and the aqueous and the lipid. And I kind of lied to you. The mucin and the aqueous layer are really more of a smear. And together they form a mucin aqueous gel. And if we look more microscopically at the cornea, you see there's multiple different cell layers in the cornea, and these top cell layers actually will die over time if they become dried out. So we need to keep the cornea well lubricated, and that lipid layer on the top that we talked about before is the barrier to evaporation of the tear film. So what happens if that lipid layer is perturbed? Well, it breaks up, and the result of this is that you can have a toxic tear, and again we'll talk more about toxic tear syndrome later. You can have rapid tear evaporation because you don't have that shield, that barrier of lipid over the water, and so now the water can evaporate up between the oil globules, and you get all this glare or dazzle in bright light. What happens is it's like looking through an oil slick or an oil film. You don't have that nice optical smooth surface. So how do you know if you have a tear film problem? Well, truthfully, an assessment should be made by a skilled slit lamp examiner, and this person, this expert in dry eye problems, might perform any or all of these studies: multiple stains, Schirmer's test, breakup time, a number of biopsies. They might do some corneal thickness determination, some lipid serum analysis, and they might do a bunch of these other immunohistochemical studies. And then they might take all this information, they might put it into this complex algorithm and figure out exactly what kind of a tear film problem you have. Of course, this is too complicated. Let's keep this more simple. How can you tell if you have a tear film problem? Well, here's a simple way. You can take 2 drops of a topical anesthetic. This is a numbing eye drop. Every eye doctor has this. Put 2 drops in each eye and wait 5 minutes. And what this does is it takes away the irritant that's irritating the eye, and if there's anything irritating your eye, it numbs it up so now you won't blink in response to that irritation to the eye. That's what I call test 1. And I can see some very remarkable differences in patients with blepharospasm. You put the anesthetic in, and their eyes stop blinking. So even though they may have benign essential blepharospasm, the secondary blepharospasm on top of that creates more of a problem, and this helps to recognize that that exists. The second test that you can do after you put in this topical anesthetic is you can rinse the eye with eye wash solution, a steady stream for 3 to 5 seconds. Why? Well, if there's a problematic tear film, a tear film with a lot of oil in it, this rinses out the oil. It gives a better optical situation. And as I told you before, if you have a disturbance of the vision, such as the wrong pair of glasses, you may blink frequently. This rinses out that oil and now allows you to see more clearly. And this might also suddenly decrease the amount of blepharospasm. The third thing that you can do, what I call test 2B, or the second part of improving the optical situation, is now turn down the room lights and take away some of that extra glare in the room. And if you do these 3 things, the topical anesthetic, rinsing out the eye, dimming the lights, you may see a significant improvement in the blepharospasm, and that tells you that tear film or dry eye is probably a significant problem for you. So aside from making blepharospasm worse, dry eye is a problem because it's uncomfortable. There can be a gritty sensation in the eyes, a foreign body sensation, irritation. That's not pleasant. It decreases your vision. We've talked about how it disturbs the optical surface and makes vision more uncomfortable. And it increases the risk of bacterial infection. If you have a dry eye, I showed you how there are many cells to the corneal surface. If those die off, now you've taken away a natural barrier to bacteria getting into the eye. And now hundreds more organisms can get into the eye, set up shop, create an infection that can create a tremendous amount of trouble. Let's talk about toxic tear and understand what that is. If you have stagnant tears on the eye, you can have a toxic tear problem. Why? Well, you may have low water component to your tear film. I told you already that there are 3 different components to the tear film: the mucin, the water, and the oil, or the lipid layer. If you have too low water, then you may have too much salt in your tear film, and this can stimulate all kinds of inflammatory molecules. A second cause of toxic tear syndrome is a primary inflammatory toxic tear syndrome, what we call eye arthritis. Patients who have arthritis, rheumatoid arthritis, might get something called a Sjogren's syndrome, where they have all these inflammatory molecules in their tear film. If it's stagnant on the eye, you don't have a good flow, you don't have a rapid production and a rapid outflow, then these molecules can sit in the eye and create a tremendous amount of inflammation. Bad oils. So the lipid layer may hang around on the eye for a long time, and diet can play a role in improving that. But the old oils in the tear film degrade when they come in contact with the oxygen in the air, and that can create a lot of irritation. So now you understand how if you don't have a good production, a good outflow, if you just have a low production and you clog up the tear drain with punctal plugs and you don't improve the tear quality, you may develop a toxic tear syndrome, which is just as irritating to the eye as not having any fluid on the eye. Now, I want to spend just a couple minutes giving you a little bit better understanding of some of the biochemistry in a simplistic form of what's going on. You have some predisposing factors that are irritating the eye, whether these are allergens, environmental stress, viral infections, whatever it is that's irritating the eye. And this creates a lot of inflammatory molecules irritating the eye. These stimulate more inflammatory molecules on the eye. And then this in itself creates more of a problem with the tear production. The inflammatory molecules will turn down tear production and create an irregular tear production, so you don't have a good balance of those three components. And as you can see, once you start the inflammatory cycle, it keeps perpetuating itself. It feeds upon itself. So once you've started this cycle, it's very difficult to turn it off. And here's another way of saying the same thing. Whatever it is that starts the inflammatory process, and some people think that circulating androgens, that's a hormone in the body, protect against this inflammation. And if you decrease the androgens, that happens to all of us as we get older, you may increase the inflammation on the eye. And here are some ways that you might drop your androgen levels, increasing the inflammation on the eye. And the balance of estrogen and progesterone in particular is interesting. There are a lot of people that think that this directly influences the androgen levels, and that the androgen levels also influence this, so it's a feedback loop. And you can understand why around menopause many women will start to have problems with dry eye. And all of these things, of course, all of these hormonal changes will influence the inflammation on the eye cell surface. And again, once you have this inflammation taking hold, you turn on other cells that create more inflammation. You have decreased tear production, and it makes the benign essential blepharospasm much worse. Again, another way to look at the same picture for those of us that are more visually oriented. Here's the normal eye surface. Tear film bathes it. We get a message back to the brain that says, hey, we're doing great, but we want a little bit more tear production. Okay, so the brain tells the glands around the eye and the eyelids, make a little bit more tear. Everything's going well. The eye is very happy, very healthy, well lubricated. When we have an inflammatory problem, this turns off the message back to the brain. You don't get the same nice messages back to the glands. You have an irregular, imbalanced tear film. This creates more inflammation, and of course, it's a self-perpetuating problem, and it turns off your nice, normal tear production. If you want more information about a normal tear film, you want a little bit more in-depth information, here's a good website to look at, www.theocularsurface.com. So are we all doomed as we get older? Are all of our eyes going to become drier? And are those of us with blepharospasm going to be getting worse and worse and worse? Well, no, there's some hope. Now that you understand what the problem is, what can we do about it? And let's talk about managing your dry eye problem. Again, nobody's going to care as much about you as you care about yourself. Understand your problem, understand your own treatment. And we're going to talk really about 4 different things that you should be thinking about if you have a dry eye problem and that's making your blepharospasm worse. The first is Botox helping you or is it hurting you? I tell all my patients that they should keep a calendar of the effect of the Botox. So is it helping you? How much is it helping you? And I tell them keep something simple. 1, I'm doing really well. 3, I'm doing really poorly. My blepharospasm is really bad. I'm not having a good effect from the Botox. And you can superimpose on this another scale that tells you how dry your eyes feel. And you'll be very surprised, and we'll talk a little bit about this later, about how your dry eye problem may lag just shortly behind the days that you're not having a good Botox effect. So that when you're having a good Botox effect, you may find that your dry eye situation is better, and when you're having a bad Botox effect or you're having worse blepharospasm, a couple days later or the next day, you may begin to see a worsening of your dry eye problem, and we'll talk about that more. But keep a calendar and for yourself and for your physician so that you know how well the Botox is working. And your calendar may look something like this. This is helpful because it helps to prove to the insurance companies that you're really having a problem and that the Botox is really helping you and that they should continue to provide funding for that. It also helps you to identify maybe you have a funny change. All of a sudden, for 4 or 5 days, your blepharospasm was particularly bad, and you might be able to go back and figure out, well, that's when I go visit Aunt Tilda, and Aunt Tilda has cats, and I now recognize that I have a real problem with my allergies, and that makes my blepharospasm really worse. And again, as I said, it shows a pattern to tailor your Botox treatment. So this is what the graph might look like over time. If you take those numbers and now you put them into a graph and you look at the effect of Botox over time, this is what it should look like. You see a rapid rise, a steady state of improvement, and then a rapid decline in the effect of Botox. And when I look at these maps that are generated by my patients, I look to see, first of all, how long did it take for the Botox to have effect? How long did it take for them to have maximum benefit once the Botox started to have an effect? How long did the maximum benefit last? And how much benefit did they have? Was it the best it could possibly be, or was it only half as good as it possibly could be? And this helps me to guide the treatment, both the location and the amount of Botox that I'm giving patients. Now, if you superimpose on this graph when you are having dry eye and eye irritation, this is very helpful. And again, let's break that up into those different times. How long it took to have an effect, how long it took to have maximum effect, and how long you had your maximum effect. And if you look at this graph and superimpose on that the time that your eyes are really dry, and that's what the orange bar at the bottom reflects, how long the period of time in which the eyes were really dry, this to me suggests that you're having too much Botox, that you're not able to blink enough and your eyes are drying out. If, however, your dry eye pattern falls towards the beginning and towards the end of your Botox treatment, then that tells me that you're not getting enough Botox. Now, we all understand how too much Botox can create a dry eye. You have too much Botox, you can't blink, you can't close your eyes dry out. That's a problem. So decreased eyelid closure, we know that blinking lubricates the eye. And there can also be an effect of the toxin directly on the tear gland. And that really depends on where the injections are given. So how can too little Botox create a dry eye? Well, we have this thing that we've called in our practice frontalis antagonist blink syndrome, and you can just call it FAB syndrome. And what this really means is that when we're frequently blinking, we're spasming, and I'm trying to keep my eyes open, and I struggle to keep my eyes open, and I raise my brow, and I'm fighting the blink. Now I'm getting an incomplete blink. I'm not getting that regular eye closure, so I'm not allowing my eye to be lubricated. I'm fighting every time my eye closes. And this is actually counterproductive. And if I gave a little bit more Botox, I wouldn't be having so much spasm, and then I wouldn't have to fight the spasm, and I'd have a more regular blink. And I frequently recommend to patients that they do a slow, relaxed blink, that the eyes close. Let them close, but under your direction. So when you feel that spasming happening, allow your eye to close fully, completely, slowly, and then open. And if you're suffering from this FABS problem, you'll find that actually that controlled, slow blink now allows you to open your eye more. We talked about Botox effects. You can direct by directing your physician whether you should be getting more or less Botox. What about other medications? Well, we know that many systemic medications, such as blood pressure medications, cholesterol modifying agents in particular, antidepressants, heart rhythm stabilizing agents, if you have irregular heartbeats, you might be on medication. All of these medications will create dry eye problems. Parkinson's disease medications. Antihistamines are probably the worst. And so if you're on a new medication and you're having a problem with it and your eyes are getting more dry, go back to your physician and tell them, can I try something else? Many topical agents will also cause dry eye problems, and in particular, they do it through preservatives, such as in tear supplements, or if you're taking glaucoma medications. Many of your glaucoma medications can cause eye irritation, and remember now we're talking about any irritation to the eye being a dry eye problem, and they may also have preservatives in them that cause a problem. What can you do about managing dry eye problems at night? Well, nighttime problems are usually a mechanical problem, a problem with the eyelid closing. And there can be many reasons why you would have a problem with your eyelid closing, especially for blepharospasm patients. These would be patients who have had surgery already, either myectomies or droopy eyelid repair or very aggressive blepharoplasty where maybe a little bit too much skin was taken out or maybe there's a little bit of scarring. So if you've had surgery on your eyelids, you might have a problem with the eyelids closing at night. Ointments are very effective at night. Lacrolube is perhaps the easiest. Vaseline is very inexpensive, but it is very blurring and you'll have to rinse it out in the morning. Avoid ceiling fans and dry heat directly above you. Closing devices, things that help you to close your eye more completely. You can tape your eyes closed, of course, or you can get a weighted sleep mask. You can get a sleep mask and you can put sand on it, in it, build your own or buy one that has some weight that will hold the eyelids closed. Now, a regular sleep mask doesn't really do you much good other than to block the breeze from a ceiling fan, but a weighted sleep mask will help your eye to close completely. External gold weights, these are wonderful. They cost $60 to $70. Any doctor can order them for you. You can't order them yourself, unfortunately. But they cost about $60 or $70, and you tape them to the upper eyelid at night. And as long as your head is slightly elevated, it will close your eye completely. And to elevate your head at night, I recommend putting a couple of bricks under the feet at the head of the bed. If you sleep on extra pillows, that may hurt your back and your neck. So just raise the whole bed slightly with some bricks at the feet, under the feet at the head of the bed. And if you sleep on your back, the external gold weights are wonderful. Moisture chambers. There are many different kinds of moisture chambers that you can put on. Swimming goggles are an extreme, but they're very helpful. Saran wrap and Vaseline is a mess, but if you want a moisture chamber, you can put Vaseline around your eye, cut out a piece of saran wrap and stick it to the Vaseline, and that creates a moisture chamber, keeps fluid on your eye. Surgeries. There are many kinds of surgeries that can help you if you're having a problem with closing your eye at night. You can partially suture the eyes closed, especially out in the outside corners. You can make the eyelids more droopy, drop the eyelid height. And if you're having a problem that's due to a previous surgery, that can be reversed. So correct existing eyelid problems. Daytime problems. Here are different things that you can do, and we'll talk about these individually. Lifestyle change, lubrication, tear improvement, tear conservation, immune modulation, and new therapies. Let's talk first about lifestyle changes. Put yourself in a situation that has increased humidity. Now here in Texas, and Houston in particular, that's a crazy thing to say, But you may find that in over air-conditioned buildings, there's very low humidity, and you might actually need a humidifier. Avoid wind, dry heat situations, high altitude, smog, smoke, exhaust, prolonged reading or computer use, soft contact lens wear. All of these things will dry your eye out more. If you must work at the computer for prolonged periods, do a slow, regular blink. This lubricates your eye. What happens when you read or you work at the computer for prolonged periods, you focus and concentrate, especially if you have blepharospasm, trying to decrease your blink rate, and you get yourself into trouble. So again, slow, frequent blinking will help you. Eye shields or goggles. You can wear these things to keep out the breeze and the extra wind that's blowing across your eye. Dr. Richard Yee in Houston has developed a gasket that can fit over anybody's spectacles, and this can cut down the breeze and really be much more comfortable and cut down glare as well. They also sell special spectacles that are made specifically for cutting down the glare and cutting down breeze, but this gasket can fit over anybody's existing glasses. So during the day, lubrication is very, very important. And there are all kinds of different artificial lubricants. You can use preserved tears. We've talked a little bit about how preserved tears will create a problem for some patients who have allergies to these preservatives. We have transiently preserved tears, so tears that have preservative in them, but when you put the tear on the eye, it then dissolves. We have non-preserved tears, which are probably the best thing to use if you're using tears frequently. There are many different kinds of ointments. They're very effective, but they're vision blurring. The thicker the ointment, the longer it lasts, the better protection it is, but the more it blurs the vision. There are a couple of tricks that you can do. One is to put an ointment in one eye, wait about 20-30 minutes, and then put it in the other eye. And this allows you to keep both eyes well lubricated while you have good vision at all times. There are also inserts that can slowly release lubrication in the eye. They're very effective, but they're uncomfortable. For many people, they find them uncomfortable. Probably the most popular brands, and I have no financial interest in any of these drops, but my patients tell me that perhaps the most popular brands are Systane, Gentile, Gel, TheraTears, Bion Tears, and most of these come in many different flavors. The Refresh line is also very popular. When I say they come in different flavors, they come in different thicknesses. And we can talk about improving the quality of your tear film. Warm compresses are very effective. What the warm compresses do is they melt the oils that are in the glands and get them out more evenly so that you don't have these stagnating oils in your tear film. Omega-3 fatty acids, fish oil, are very effective in improving the quality of the tear film. Flaxseed oil is very effective as well. Both the omega-3 fatty acids and the flaxseed oil are much better absorbed if you take them with a sulfonated protein. And tempura is a sulfonated protein. Perhaps more popular and easy to get hold of is peanut butter. So if you take omega-3 fatty acids or flaxseed oil with a little bit of peanut butter, that makes it much better absorbed. And I always tell patients that if you're going to take flaxseed oil, you should take the actual oil, not the capsules. The capsules do not dissolve very well. If you must take the capsules, poke holes in them with a pin, and then you'll be able to take benefit from the flaxseed oil. Estrogen-like foods, there's a lot of controversy about whether this improves the tear film or not. Remember, we talked about how an imbalance between progesterone and estrogen and androgens can affect the tear quality. Some people think that estrogen-like foods improve the tear film. Others strongly argue against it. I don't really know the answer, but it's certainly a topic of controversy. Estrogen foods in particular, estrogen analogs can be found in soy and many nuts. Vitamin A and acetylcysteine can be very effective in improving the tear film quality. Acetylcysteine, mucomist, is good for people who have very thick mucoid tears and have a problem with that mucin layer of their tear film. The tetracyclines are very effective. They're anti-inflammatory at low dose. Aladox is 20 milligrams of doxycycline, and you don't have to take the 100 milligram capsule. You can take the Aladox, and that's very effective in decreasing inflammation in the eye. Tea tree oil for anterior lid margin disease. There are different kinds of blepharitis or inflammation of the eyelid that can affect the tear film quality. And for people that have anterior lid margin disease, this has to be diagnosed by your doctor, but you might see it yourself if you look very closely in a magnified mirror. You might see some crusting and flaking on the eyelashes. That's typically an anterior lid margin disease, and tea tree oil can be very effective for that. And OcuSoft scrubs are also very good for anterior lid margin disease. And again, some of these treatments ought to be directed by your physician, but if you bring these to their attention, they can help guide you in treatment. Tear conservation. So how can we keep good tears more on the eye? Punctal occlusion. We talked about closing up the tear drains. That's only a good idea if your tear quality is good. If you have bad tear quality, it can give you a toxic tear syndrome and create more inflammation and create a bigger problem. Tarsorrhaphy, closing down the eyelids, sewing the upper and lower eyelids together a little bit toward the corner. This decreases the rate of evaporation, increases tear conservation. Moisture chamber goggles, we talked about that for nighttime use. Some people use them during the day, and they sell commercially goggles that have a little foam rubber around them that decrease the rate of evaporation of your tears. The Boston scleral lens is a tremendous innovation. This is for people with profound dry eye problems, and it's a lens that sits on the eye. This picture on the right shows the eye in profile or from the side, and you can see that the cornea in the bright white line is now covered over by a lens that has a little reservoir that holds fluid. So this contact lens holds fluid on the eye and can slowly release it onto the eye, and you put a little bit more liquid into the contact lens a couple times a day. So here's the situation we would like. We'd like to have good homeostasis. We'd like to avoid the toxic tear syndrome. And the best management of toxic tear syndrome is to increase the outflow and increase the inflow and increase the outflow to the eye, and that way you wash that toxic tear off the eye. Immune modulation. Well, tetracyclines are very effective. We talked about that a little bit. Immune modulation means turning down the inflammation on the eye. Corticosteroids, steroid drops, these can decrease the inflammation on the eye. Cyclosporin or Restasis, this can decrease the inflammation in the eye. It takes about 3 months to be effective. And then there are other cytokine inhibitors, other medications that can turn down the inflammation in the eye. And the new therapies that are on the horizon for helping patients that have dry eye problems are drops that increase the production of the tears. And here are a couple of different names of things that are currently under investigation. And we talked again a couple of times already about different hormonal therapy. Now there are some hormones being tried as drops on the eye. And here is something that's being done in Spain. They are implanting a pump into the abdomen with a tube that comes all the way up to the eye and slowly releases tears onto the eye. Maybe that'll catch on. So daytime dry eye, just to review, we talked a little bit about lifestyle changes, things that you can do to decrease challenges to the eye, decrease evaporation. We talked about different kinds of lubrication that you can put in the eye, ways to improve the quality of the tear film, ways to improve the conservation of the tear film so it doesn't keep evaporating away. We talked about immune modulation, so in patients that have a toxic tear problem that's creating inflammation, how to turn that inflammation down. And we talked about some new therapies that are on the horizon for daytime treatment of dry eye problems. We talked about overall the botox effects, modifying the botox dose and pattern. We talked about changing other medications that you might be taking, talking to your doctor about, hey, I was doing great until I started this new anti-cholesterol medication, this Lipitor, and now I'm having a lot of trouble with dry eye. Can we choose another medication? We talked about nighttime problems. This is really a mechanical issue and things you can do to help with that. And again, we talked about daytime problems. An important disclaimer. First of all, I want to say that I've mentioned a number of different products. I don't have any financial interest, unfortunately, in any of these products. But more importantly, I am not a dry eye expert. I'm giving you my experience with treating dry eye in my blepharospasm patients. And really, if you're having a dry eye problem, or if you want to know if you have a dry eye problem, you ought to seek an expert in that field. So somebody who's an anterior segment specialist. There are 9 different specialties in ophthalmology, and you can find somebody who specializes specifically in tear film and dry eye. And then I would help to guide them in helping you by telling them what you think your problem is based on the things that you've learned here today. Thanks very much for your attention. I hope that this has been helpful to you, and perhaps this can stimulate some discussion, and you can discover from other patients that have blepharospasm things that have worked for them with their dry eye problems. Thank you.